task assigned to me is liver in type 2 diabetes. Is it the cause or the effect of metabolic syndrome? So, what I'm going to do is to explore the complex relationship between liver and diabetes, try to understand the liver metabolic role in type 2 diabetes, which seems again very, very complex. Whether liver is a villain with insulin resistance leading to glucose and lipid dysregulation, whether liver is a victim which pays ultimately for insulin resistance, MASLD, fibrosis, and cirrhosis. And toward the end, the takeaways and the future directions for its management. So it is always like egg and hen theory, what came first, whether it is insulin resistance or type 2 diabetes, or it is the MSCLD, which then sets in the stage for development of type 2 diabetes. So let's go back to our physiology days and try to understand that what came first. There's a huge evidence today that it is insulin resistance, which is a core defect which comes much, much earlier before the onset of even IGT or type 2 diabetes. In response to that, you have a growing beta cell dysfunction. Initially, there is a hyperinsulinemia to compensate for insulin resistance, but ultimately it is the beta cell failure which sets in the stage for development of type 2 diabetes. And per se, because of that, you have onset of postprandial hyperglycemia and subsequently the fasting hyperglycemia setting in. So when it comes to diabetes and liver disease, at least we understand they share a bidirectional dynamic relationship, because both the problems have important interaction considering its etiology and the presence of any problem into one organ ultimately leading on to dysfunction of the other organ. That means if you have insulin resistance leading on to type 2 diabetes, you are going to have per se hepatopathy. If you have already onset of MASLD, NASH, fibrosis, and then onset of type 2 diabetes. Because we know that liver is the main organ which is concerned with glucose homeostasis. It is glycogenesis which goes on in the postprandial state we are just now because of release of insulin, and that leads on to deposition of glycogen. But moment we are fasting under the impact of glucagon, we have glycogenolysis and nucleogenesis contributing towards prevention of hypoglycemia in a normal glucose tolerant patient. So it is insulin resistance which is the root cause for the development of both adults onset type 2 diabetes as well as MASLD. So moment you have insulin resistance, it gets compensated, I told you in the beginning, by hyperinsulinemia. But per se, moment there is an onset of beta cell failure, there is an onset of hypoglycemia, it leads on to adipocyte dysfunction, reduction in adiponectin levels, free fatty acid levels are on the higher side, and so is sudden increase in triglyceride. And we know there are sterol regulatory element binding protein 1C, which is a transcription factor that plays a crucial role in regulating lipid metabolism as well as fatty acid synthesis. And so is carbohydrate response element binding protein, again regulating both lipid as well as glucose metabolism. So as long as there is a healthy liver and you don't have severe insulin resistance, moment there is an increase in insulin resistance per se leading on to some degree of beta cell dysfunction, hyperinsulinemia, that leads on to onset of what we as laymen say a fatty liver. And there is a lipotoxicity which then gets converted into NASH. There is a subsequent fibrosis, clinically significant fibrosis, onset of type 2 diabetes, and also there is towards the end a and say liver disease. And mind it is being predisposed to two factors. One is the genetic predisposition for development of MESL, and second is the environmental factors, the dietary factors, the sedentary lifestyle, all playing together. So it's a very, very complex, dynamic, bidirectional relationship between liver as well as into the glucose metabolism which goes on. The major pathways which induce NAFLD and their association with insulin resistance, diabetes, cardiovascular disease, non-alcoholic fatty liver disease, and end-stage fibrosis then could be either there is a strong hepatic genetic component. It is not only that you are being predisposed for development of diabetes at a early stage, maybe 1 to 2 decades earlier as compared to the Caucasian. You are also predisposed for a NAFLD, which also gets predisposed through various genes, which lead on to some degree of adiposity through induction of insulin resistance, NASH, and fibrosis. But it is also being predisposed through strong lifestyle, adipose tissue deposit component, which is again predominantly driven by de novo lipogenesis on one end and predominantly driven by adipose tissue dysfunction on other end. So both playing together in a sedentary lifestyle, your efflux of carbohydrate or diet intake is much higher, and then it leads on to NAFLD and progression into MASLD and end-stage liver disease. So moment you have insulin resistant state, it is directly going to be toxic to the hepatocytes. Again, trying to give you through a diagram that moment there is an increase in insulin resistance and hyperinsulinemia, that leads on to adipocyte dysfunction, reduction in adiponectin levels, leptin and TNF-alpha are on the higher side. There are higher free fatty acid levels. De novo lipogenesis is already onset, and that leads on to severe oxidative stress through the mitochondrium, and then that predisposes again for more steatosis, steatohepatitis, clinically significant fibrosis, and this process then goes on in its in terms of natural course of the disease over the time, over few years time. So the putative mechanisms which underlie the contribution or which lead on to development of NAFLD to the increased risk of further development of CVD as well as type 2 diabetes. Mind it, everyone who has a NAFLD or MASLD does not have diabetes per se. So if you have onset of NAFLD or NASH already there, that not only increases the risk of CVD, but also towards the onset of adult onset type 2 diabetes, because through worsening of insulin resistance and further progression of NAFLD with free fatty acid production and inflammatory cytokines and reduction in adiponectin, it leads on to all the markers of inflammation going on the higher side like fetulin A and RBP4, CRPs, interleukin 6, TNF-alpha, high triglyceride production, and increases small dense lipoprotein, which again worsens the scenario for developing of CVD, and there is going to be a further expansion of the visceral fat leading on to adiposopathy. And this process again goes on leading on to, through I told you, through either through the sterol response element proteins or through carbohydrate responsive element binding proteins, and this further leads on to worsening of chronic liver disease and a end stage cirrhosis. So not only there is a effect of development of MESLD on onset of type 2 diabetes, there is also per se effect of the diabetes on CLD, because moment you have worsening of insulin resistance, there is going to be a not only a increased risk for MESLD and clinical significant fibrosis, but also there is going to be a further progression towards cirrhosis, which also increases the risk of HCC, which is very, very high, almost 2 to 3 times higher in type 2 diabetes as compared to someone who is not having diabetes. So it is not only insulin resistance or hyperglycemia which worsens MESLD, but the liver disease onset per se or chronic liver disease, that also is going to impact on glucose control in two forms. There could be a predisposition to hyperglycemia, which is although not very frequent, but it is not very rare. It is usually seen when you have an acute and chronic liver failure in a terminal cirrhosis, or with the development of HCC, that you tend to get frequent episodes of hyperglycemia because there is hardly glycogen deposit by then, and it on the other end, contrary to that, it can impair your glucose intolerance and actually lead on to the onset of what is known as a hepatogenesis diabetes, which is for the first time developing in someone who already has cirrhosis, or even in patient those who already have a post liver transplant situation or with HCC. So this association, trust me, is not by chance. Insulin resistance leading on to type 2 diabetes, also setting up a stage for development of nephral or cirrhosis or HCC. But with the development of cirrhosis, you are also at a greater risk for developing hepatogenous diabetes. So it must be viewed as a continuum of the same phenomena, with core defect being an insulin resistance. So it is a vicious cycle. How liver disease and type 2 diabetes, they feed each other. Nephral prevalence is very, very high, up to 70%, or many studies saying up to 90% in the setting of type 2 diabetes. And with insulin resistance, that steatohepatitis with fibrosis going on further with profound insulin resistance also tend to impair your glucose control, leading on to hepatogenous diabetes, and together they lead on to an accelerated damage in the form of high risk for developing cirrhosis, liver cancer, or liver failure. So this is actually a bidirectional relationship which creates all the more a dangerous feedback loop, where each condition actually exacerbates the other. So that is why today unfortunately the nephral prevalence is very, very high, and it must be viewed as a elephant in room. What we have been talking about, heart failure in diabetes, even nephral is as bad as is that, because there is going to be a much higher mortality. And if you compare it in diabetic versus non-diabetic, in diabetic, the progression of fibrosis over 12 years is much higher as compared to someone who has no onset of diabetes yet. And there is going to be higher prevalence of clinical significant liver fibrosis in these patients. A published data in IGM 2024, Indian authors talking about that higher BMI, AST, ALT values, as well as lower platelet count, we all know are going to predispose to chronic clinically significant liver fibrosis. But mind it, it is not always ALT or AST which are going to be directly precursor of that. Many times your enzymes may be still just borderline, and you might have a clinically significant liver fibrosis. So this study highlights the importance of screening for liver fibrosis much in advance, not only depending on the enzymes. And it is known that in type 2 diabetes, the progression of nephral to cirrhosis is also going to worsen the mortality, because mortality is much higher if you are already at the end of NASH, cirrhosis, or HCC. Not only that, I told you in the bidirectional flow again, nephral also leads on to new onset of type 2 diabetes. Even if you were not diabetic, you were simply an obese with nephral, you are at a much greater risk for developing new onset of type 2 diabetes. So not only the genetic factors which are important, the double agent gene variant is extremely important, because this variant can both accelerate liver fat accumulation. I told you predisposition only for increased liver fat deposition. So you need to have a precision medicine. Today we are not only talking about precision medicine in type 2 diabetes, but also in management of liver, and we must try to understand these genetic nuances which have significant implication for developing highly tailored treatment, and be having more predictive risk factors or models for that, because genetics adds another layer of complexity to liver involvement in setting of type 2 diabetes. And we understand there are going to be modifiable as well as non-modifiable risk factor. Non-modifiable, I told you, couple of genes which predispose for greater fat deposition, aging phenomena itself, and of course the modifiable risk factor in the form of weight regression and diet and exercise, which is going to be extremely important. So towards the end, I must tell you that liver disease possibly today is the leading cause of death in setting of type 2 diabetes. It is no more CVD or heart failure, but it is actually a diabetes related NASH, finally culminating into cirrhosis, which is going to have a very, very high mortality in these patients. So we must screen this patient with either FIB score or BARD or BART or EPRI or maybe NFS. There are lot of tools which are available for prediction of fibrosis in these patients, do a regular annual screening, but the challenges are that we need to specify and the practical feasibility of having a widespread implementation across healthcare systems and improving an access to and having an awareness of these screening tools possibly is going to be of paramount importance for a early intervention. And then only probably, just last one slide, we can, if we intervene early, we probably can check the progression from stress adipocytes toward hepatic lipotoxicity, inflammation, cirrhosis, and end-stage renal disease by intervening at each step. In the beginning, it may be lifestyle modification, then drugs to improve insulin resistance, to improve disposal of free fatty acids, reduce inflammation, and toward then antifibrotic drugs are fortunately now available which can check the progression towards cirrhosis. Weight loss is going to be extremely important. Drugs like semaglutide or Monjaro or the novel therapies which are already available, approved by US FDA, thyroid hormone receptor binding agonists, which are very, very expensive, not available in this part of the world. And of course, the last option is the bariatric surgery. So to sum it up, liver could be seen as a victim when we talk about sustained high glucose and insulin levels along with fat accumulation, but it could also be playing a role as a villain when we talk about insulin resistance, which not only impairs glucose production, but also contributes towards worsening of overall blood sugar control and leading on to hepatopathy. And understanding this intricate self-perpetuating cycle is going to be extremely important in terms of prevention and improve patient survival. Thank you very much for your patience listening.